Lung adenocarcinoma is not one disease. It can now be parsed out into distinct genetic alterations or genetic subsets that are generally mutually exclusive. That now, if we can identify these genetic subsets, we can allow the patient to receive targeted therapies versus chemotherapy. And there's a lot of heterogeneity. Of course, there's EGFR-mutant lung cancer, there's KRAS, there's HER2, there's BRAF, there's MET exon 14 skipping mutations, there's ROS, there's RET. It's very confusing, but the bottom line is that each of these cancers behaves differently and responds differently based on what targeted therapy you're going to give them. And it really just speaks and underscores the importance of comprehensive genomic profiling. One lung adenocarcinoma that walks through the door may be very different, behave differently, respond differently than another lung adenocarcinoma that walks through the door. So there's a lot of heterogeneity, and that heterogeneity speaks volumes to the fact that we need to make sure these patients have comprehensive genomic profiling as they walk through.
EGFR mutations are very interesting because we have discovered that the prevalence of the mutation depends on the ethnicity of the person. For example, in Caucasian populations, maybe 10 to 15% of the patients can carry these genetic aberrations. However, in Japanese, in Asian, like Chinese populations, these genetic aberrations can be like 40 or 45% of the patients with lung cancer. And I have personally published in Latin America for Hispanic patients, for example, the genetic aberrations are in the middle, between probably 25, 30, or in some countries, 35% of the patients. So that will depend on the ethnicity of the patient to see what is the frequency of the one of these EGFR mutations. We have been discovering that there is a lot of mutations in this EGFR gene, and especially because in the old times we used to do like a hotspot only. We only analyze one area of the gene, but now we know that there are several areas of the gene that can have mutations. For example, the two most common mutations are the one that are the exon 19 and the exon 21. In these two areas of the gene, we have like close to 90% of all the mutations. However, there is probably 10% of mutations that are in other areas of the gene, including exon 20. And commercially speaking, a lot of industry vendors only test for the most common ones because it's more work to test for the uncommon ones. However, we need to do probably a comprehensive analysis of the gene, because you can say, oh, we're only missing 10% of the patients, but lung cancer is a very prevalent disease. You are talking about 225,000 Americans every year with lung cancer as a new patients. So if you miss 10% of the patients, you're missing a lot of people. That's why we advocate the use of next generation sequencing, so we do a whole testing of the gene, so we're not missing even these small populations of mutations that can be relevant or could be resistant for the treatment with tyrosine kinase inhibitors.
It's important to note that not all EGFR mutations are the same. The most common EGFR mutations, exon 19 deletions and L858R, exon 21, those are the mutations that are more likely to confer sensitivity. If you have a mutation in DEL19 or 21, these patients should be offered in their advanced stage. These patients should be offered frontline TKI with either gefitinib or lotinib or afatinib. The story gets a little more confusing with other more rare EGFR mutations. For instance, EGFR exon 18 mutations. It depends on the type of mutation it is. Some are resistant, some are sensitive. The one that I think we know for the most part is resistant to TKIs is exon 20. Exon 20 mutations in T790M is an exon 20 mutation, but exon 20 mutations, if identified up front, should not be offered a TKI. These patients should generally be given chemotherapy, and that's an important message to the community that not only is not all lung cancer the same, but not all EGFR mutations are the same. The 19 and 21s predict sensitivity. The 20s generally confer resistance. The exon 18, really individualized. You have to really think hard and look up the data on which 18s may be sensitive versus resistant to TKIs.